Hello, yes. Can you hear me now?
Mm-hmm.
Okay. Okay, question 31. A 27 a 27-year-old man with asthma comes to the emergency department because of progressive shortness of breath and wheezing for 24 hours. His symptoms began 1 week ago with increasing wheezing. Treatment with inhaled beta adrenergic agonist, uh, treatment with inhaled beta adrenergic agonist and corticosteroid has been ineffective. He appears mildly dehydrated and in moderate to severe respiratory distress with labor breathing and the use of accessory muscle. His pulse are 90 per minute, respiration 30 per minute, blood pressure 130 by 80, ABG pH 7.35, PCO2 51, PO2 65, and bicarbonate 20. Which of the following is most likely? Okay, ready?
Okay. Yes. Oh, wait, I missed something. Okay, now wait. The next one. Mixed respiratory metabolic acidosis. Asthma is characterized by reversible obstruction to airflow caused by spasm of smooth muscle in the bronchi and smaller ways. Asthma often presents with episodic exacerbation that can be triggered by an allergen or other environmental exposure, exercise, or seasonal changes. Exacerbation present with shortness of breath, cough, tachypnea, increased work of breathing, wheezing, hypoxemia. Variety of acid-based disturbance can occur in the setting of asthma. Mild asthma exacerbation may lead to hyperventilation and respiratory alkalosis. This patient IBG analysis shows an anion gap metabolic acidosis identified by a pH of less than 7.30. Acidemia with decreased bicarb and increased PCO2. Inadequate respiratory ventilation may lead to hypoxemia, which in turn can cause metabolic acidosis due to organ anaerobic metabolism and production of lactate. Respiratory acidosis can also occur in the setting of severe exacerbation with significant degrees of airway obstruction, leading to retention of CO2. Despite tachypnea and increased work of breathing, Winter's formula can be used to determine if there is appropriate respiratory compensation for this patient metabolic acidosis, or if there is, or if an additional respiratory acidosis is also present. This patient's formula yields an expected PCO2 of 36 to 40. This patient therefore has both metabolic acidosis due to hypoxia and end organ lactate production and additional respiratory acidosis due to airway obstruction and CO2 retention. Next.
Yes. A 16-year-old girl comes to the office because of 1 month history of green sticky discharge from the nipple. She initially noticed the discharge on her bra and was also able to express it manually. She has not had a breast pain or skin changes during the past 3 months. She has had 4.5 kg weight gain despite no changes in the appetite. She has had frequent frontal headaches since beginning or OCP 3 months ago. 6 months ago, she was diagnosed with MDT and was started fluoxetine therapy. Months are regular 28 days of interval. Her last menstrual period was 2 weeks ago. She is sexually active with one male partner. Use condom inconsistently. Um, Examination scanned grayish discharge can be expressed from the right breast. The remainder of the examination shows which of the following is the most appropriate. Ready?
Mhm. What's happening? Doctor ectasia. This patient who's perimenopausal and presenting with unilateral green sticky nipple discharge is most likely experiencing mammary duct ectasia. Um, Mammary duct ectasia refers to widening in the lactiferous duct, often near the nipple, that is associated with inflammation. These ectatic ducts are often asymptomatic until they become blocked, at which time they may become painful and nodular or cystic. Multicolor or green sticky discharge is pathognomonic. While nipple discharge is a common occurrence in adult women, it is much less common in adolescents and teenagers. Evaluation should include a complete history and physical exam focusing on whether the discharge is unilateral, bilateral, its characteristics, and its provoking factors. History should include a detailed medication reconciliation, and some medications may be associated with nipple discharge. Physical examination should validate for breast anomaly, including breast mass or pain or fluctuance. Lab may include a culture of the discharge to rule out underlying infection. And ultrasound can be used to confirm the diagnosis of ductal. Complications include infections such as mastitis, breast abscess. Treatment is primarily symptomatic, although surgery can be used to treat patients who do not respond to non-invasive treatment. Next.
A 14-year-old girl is brought to the physician by her mother because she has never had menstrual period. The patient has no history of serious illness, takes no medication, therapy begins 18 months ago. Her mother's menarche was at 13 years. At the age of the 13 years, the patient plays soccer and runs 3 miles weekly. She is 50 percentile height, 10 percentile weight, 25th percentile BMI. Breast and pubic hair development or sexual maturity rating is stage 4. Which of the following is the most appropriate next step? Everything seems normal, isn't it?
Mm-hmm. Mm, she is 13, more than 13, with sexual characteristics, and 15 with no sexual. Wait, it's 13 sexual characteristics, 15 with no sexual characteristics. Thyroid extent, measurement of prolactin, gonadotropin, karyotype analysis. Forgot what it was. It was 13 with sexual characteristics and 14 and 15 with no. Give me a second.
Yes, no problem.
Yeah, I think it's 15 sexual characteristics. Okay. Ready?
Okay,
Ready?
what have you calculated?
Oh, you don't want me to look at it? I don't even know if I got it right. You want
No,
me
no,
to
no,
look at it?
no, no. I am just asking you, like you are calculating something. What was that? That
Oh, it was just remember there is that thing where it says that if the menarche, if your period has not started either by 13 with how do you diagnose primary amenorrhea? Is
okay,
by
that
13.
one.
Yeah, that one. Uh-huh.
Oh, Okay, okay.
Ready?
Yes, yes.
Okay, yeah, it's ready. Serious. Primary amenorrhea is described as the absence of menarche that's what I was calculating. Menarche at 15 years with appropriate sexual characteristics, with appropriate secondary sexual characteristic, or at 13 years old without secondary sexual characteristics. So 13 without secondary sexual. Okay. Prior to this, amenorrhea is not considered pathologic. Patients experiencing primary amenorrhea should undergo further evaluation to determine the cause. Common causes of primary amenorrhea include functional hypothalamic amenorrhea, constitutional delays of puberty, gonadal dysgenesis, like Turner syndrome, mullerian agenesis, hyperprolactinemia, GR, gonadotropin releasing hormone deficient PCOS, imperforated amine. Initial evaluation includes pelvic ultrasound to ensure the presence of uterus, followed by measurements of FSH, ESH, prolactin, and testosterone. This patient is 14 old and has sexual characteristics. Thus, she does not meet primary definition of the definition of primary amenorrhea. The most appropriate management is the assurance that her amenorrhea is slightly a normal value. Mhm.
Okay.
Next.
A hospitalized 57-year-old man is confused and agitated and combined and combative 2 days after undergoing laparoscopic resection for hepatocellular carcinoma. His medications are omeprazole, propranolol, hydrocodone. He has drunk 1 gallon of Scotch whiskey weekly for 3 years. He has used heroin once daily for 3 years. His temperature is 38.5 degrees Celsius, pulse 112 per minute, respiration 24 per minute, blood pressure 107 by 100 millimeter mercury. Physical examination shows tremor of the hands. On mental status examination, he is not oriented to person, place, or time, and reports seeing cockroaches on the hospital bed. Lab studies shows platelet count 46,000, prothrombin time 15, albumin 2.2, AST 66, ALT 90, amenorrhea 11. Urine toxicology is negative. Hmm, which of the following is the appropriate initial step? Ready?
Yes, it is thoracic band. This patient demonstrates confusion after resection of cancer, hepatocellular cancer, long-term complication of cirrhosis caused by alcohol use disorder. And he also shows signs of chronic liver disease, assisted synthetic liver dysfunction, including thrombocytopenia, prolonged prothrombin, and anemia consistent with cirrhosis caused by alcohol use disorder. Delirium tremens is a serious complication of alcohol withdrawal. Oh, he has delirium tremens. Alcohol use increases the CNS activity of GABA, the main inhibitory neurotransmitter. Abrupt discontinuation of alcohol therefore leads to sympathetic overuse. Overdrive. Uncomplicated alcohol withdrawal typically presents with tremors, anxiety, restlessness, headache, nausea, diaphoresis, which can occur hours after the cessation of alcohol. Delirium tremens is the most concerning and life-threatening complication of alcohol withdrawal. Involves severe confusion and disorientation, fluctuations in consciousness, agitation, visual hallucination, autonomic instability. As in this case, delirium tremens can begin 2 to 5 days after patients have last alcohol drink. Patients with delirium tremens are at risk for death associated with dysarrhythmia and respiratory failure. Delirium tremens is managed supportively with benzos um, to address agitation and prevent symptoms of withdrawal, as well as fluid nutrition or supplement and frequent assessment of vital signs. The complications that occur with drought include recurrent hallucinosis, auditory and visual hallucinations without confusion or autonomic instability, and seizures. Non-lactulose is given for prevention and treatment of hepatic encephalopathy. Many patients have increased ammonia concentration, but this patient does not. Additionally, his vital signs derangement are consistent with delirium tremens. What is the normal ammonia concentration? 15 to UGPL, 15 to 45.
Is it low?
Okay. It's low in this question. In the question,
So low ammonia significance anything?
means that it's not hepatic encephalopathy.
Okay,
Mm, okay.
ready? Next.
Yeah.
A 4-month-old girl. A 4-month-old female infant is brought to the office by her mother. Is brought to the office by her mother um, for a well child examination. She was born at term following an uncomplicated pregnancy and vaginal delivery. She is breastfeeding well and gaining weight. She has been smiling and cooing and has been rolling on onto her side. The mother says she noticed an asymmetric appearance to her daughter's face and head 4 weeks ago that has slightly worsened since that time. The patient otherwise has been well. Family history is non-contributory. The infant is 63 centimeter, 25 inch, and 50% long and weight 6200 gram. Its circumference 40 centimeter. Vital signs are within normal limit. Physical examination shows an open and flat anterior frontal and a palpable ridge from the right parietal and the parietal and the temporal bone. The right eye and the eyebrow appears superiorly displaced when compared to the left. The remainder of the examination shown. Okay, ready?
Yeah. So it's coronal craniosynostosis. Craniosynostosis refers to premature ossification that occurs between the plates of the cranial bones, leading to deformity of the skull. Premature ossification. Most infants with this condition are symptomatic. Genetic causes may involve abnormality in expression of the FGF or TGF. The fontanelles are cartilaginous gaps that exist between these bony plates that, along with the cartilaginous sutures, allow for movement, growth, and compression of the cranial bones, particularly during childbirth when the skull passes through the pelvis and vaginal canal. Closure of one or more of these regions prematurely lead to abnormal growth and fusion of the skull. The resulting deformity can be both cosmetic, abnormal head shape, and pathologic, limiting normal CNS growth. Several patterns of deformity can occur depending on which other prematurely fuses. In this patient, fusion of the coronal suture arrests the anterior posterior growth of the skull. This leads to continued medial growth in disproportion to anterior posterior direction. As a result, anterior brachycephaly and brachycephaly can develop. Because of this patient's elevated right eye compared to left eye is most likely due to corona, blah, blah, blah. It's not the position of plagiocephaly, it's the development of abnormally flat shape of the infant skull. Occipital plagiocephaly occurs as a result of the infant frequently lying on the back. For this patient, coronal cholestasis is the more likely as coronal suture fusion can be seen on CT scan of the head.
They they have given the just seeing this thing. Is it possible to diagnose cranial synostosis? Your battery.
Sorry,
I don't know why my eyes goes.
with you. The way you, it's like it's your computer. You're like, wait, hold on, your battery, your battery. Okay. The way they were giving this, is it possible to? They say yeah, you're supposed to be able to diagnose it with this. Oh, I guess it will be here. There should be a suitor here. Here, the same thing that is here should be here. And since there
Okay,
is
this
not,
is fused. That's why it is
yeah,
synostosis,
yeah.
probably.
So there
Okay,
should be something like this here. Yeah.
so you found a clue. It is good.
I mean, but I didn't. I just didn't know what, which coronas. Where is the coronal suture? Okay, this will be the lamboid or whatever. The suture will be the coronal one will be here, and then the what was this one?
Sagittal
The
one,
sagittal
sagittal.
sagittal one. Yeah, will be here at the top.
Sagittal means from the side, and coronal means probably anterior posterior, isn't it?
Coronal.
Like
Yeah,
face. Sorry.
I don't understand when they say, oh, you see on the explanation when they say, oh, if one fuses, then the anterior posterior will be blah blah blah. I didn't understand one.
Okay, leave that explanation. I
Yeah, I'm like, I don't understand that part.
yes. Your yeah, things is better. Like there should be a suture as there is no suture because we have confusion in between A and D, isn't it?
Mm-hmm, mm-hmm,
Rest of the we know that. So we have to find a clue.
mm-hmm,
Like play plagigocephaly, positional plagigocephaly. The, this is like a flattened shape of the infant skull,
mm-hmm,
but this one is not the flat. So
mm-mm.
so we can exclude from that. Okay. Okay. Don't try to remember these things because this would be hard. Like these things will
Yeah.
come one and two, and we have to like we have to leave them. Okay. A 57-year-old woman comes to the physician. She has felt sad and tearful and has thought about killing herself for the past 2 weeks. Her symptoms began 1 week later after losing $25,000 during $25,000 during a weekend of gambling. She reports that she had boundless energy all week and gambled continuously throughout the week without needing to sleep. She says, great even I felt great even when I was losing and did not realize when I had done when what I had done until a week later. Twice yearly for the past 10 years, she has had similar gambling episodes, but has never lost this much money before. Physical examination show no abnormality on mental status examination. She is distraught and tearful. She says that she has not have developed a plan to take her own life, but admits to wishing for a convenient car accident. Which of the following is the most likely diagnosis?
Hmm.
Ready?
Yes, it is bipolar disorder. I want between that and gambling. Bipolar disorder is mood disorder characterized by acute episode of mania. Acute mania typically manifests with two or more of the following, like euphoric or irritable mood, increased energy, decreased need for sleep, increased goal directed activity, rapid speech, and thinking, responsibility, like the patient gambling, grandiose thinking. Some patients demonstrate associated psychotic symptoms like paranoid delusions, hallucination, a loss of insight as evidenced by this patient lack of awareness of her deleterious actions during the manic episode is common. This patient most likely has type 1 disorder, which requires a history of mania to meet diagnostic criteria. Depressive episodes are not required for diagnosis but are common, particularly after manic episodes. As in this case, management requires mood stabilizing pharmacotherapy or antipsychotics for acute mania. Once acute mood episodes resolve, patients with bipolar disorder should continue mood stabilizing maintenance therapy to prevent future episodes of mania or depression. It's not pathologic gambling is characterized by escalating gambling habits, unsuccessful attempts to quit gambling, persistent thought about gambling, attempts to make up for lost money, functional problems as a result of gambling, and other gambling related issues. This patient gambles as part of constellation of manic symptoms. It can be secondary to mania rather than being a problem on its own.
So how we can
Next,
differentiate the pathol? This question has like clear cut two incident. Like 1 week of mania, like he lost his money on gambling, and 2 weeks of sadness, isn't it?
okay. Uh-huh.
So that's why you diagnose it as a bipolar disorder, isn't it? So
No, I didn't. I didn't look at the weeks, and I didn't remember the timeline. It was just that it was
like
mania and
for bipolar to be told, you need 1 week of mania and 2 weeks of depression, isn't it? Okay, leave the
I,
timeline. Like
yeah, yeah.
just tell me
You're
why.
probably right. I don't remember. You're probably right. I
No,
just
no,
don't remember.
no. I'm not talking about the timeline. I just want to exclude the pathological gambling. There is a word called pathological gambling.
Yeah, yeah. I was between those two too. Yeah.
Yes.
hmm
So how we can different like why it is not pathological gambling?
Uh, for me, I just went with bipolar because it was mania and depression. And
Okay.
then it's, pathologic gambling, they're saying that it's not going to be like they're gonna give you more about the gambling. Like she keeps gambling and it's getting worse. She's been doing that for years. She tried to quit, but she keeps going and she thinks about it all the time. she wants to make up the money that she lost, so she goes back to gambling, and she lost her job, and her wife left them because of the gambling and all this. Like, it's gonna be more about the gambling. Here it was like she
Okay,
did it only
now
twice.
I
Yeah, she
okay.
did it only twice in 10 years. It's 10 years. She only did this twice,
Yes.
and then she was feeling bad after, so she had depression, and then I don't know. It just wasn't a lot about gambling. Oh, and then all the symptoms of mania were decreased need for sleep and um, talking fast and all these things. Yeah, those are also symptoms from them.
Okay. A previously healthy 57-year-old woman comes to the office, 2 weeks of fever, non-productive cough, increased shortness of breath. She is no longer able to wake up one flight of stairs without resting. She takes no medication. She does not smoke cigarettes, drink alcohol, or illicit drugs. She has been sexually active with multiple partners. They use condom inconsistently. She appears cigarettes. She appears cachectic and in moderate respiratory distress. Her temperature is 39.1 degrees Celsius, pulse 120 per minute, respiration 32 per minute, and blood pressure 104 by 68. Examination shows submental and cervical lymphadenopathy. There is a diffuse white exudate over the buccal mucosa. Pulmonary examination shows good ear movement and no crackles. Bronchi are hard. The remainder of the examination shows no abnormality. Her hemoglobin is 7.8. Leukocyte count is 3,800 per millimeter of cube. APG analysis on the room here shows pH 7.48, PCO2 30, PO2 68. An X-ray of the chest show no abnormality. Which of the following is the most likely causal organism? Um,
Hemoglobin is low, and respiratory fibrosis. Cytopenia. Mm. Strep pneumo is lower pneumonia. That makes sense. No, no.
Ready?
One moment. Then does not make that much sense, but okay. Yeah. It's PCP pneumonia. Then PCP is opportunistic yeast-like fungal organism that causes pneumonia in immunocompromised patients. Chest X-ray typically show diffuse bilateral infiltrate that often prominently about the hilum. Though as seen in this patient, chest X-ray can also show no abnormalities. Did not know that. Methenamine silver or toluidine blue stains, toluidine blue stains selectively stain the cyst wall and are used to confirm diagnosis. PCP primarily affects immunosuppressed patient. The patient likely has HIV and is in addiction. As in addition, PCP pneumonia, the patient has a history of multiple sexual partner and consistent condom use. The cervical lymphadenopathy And white X-rays and buccal mucus also support the diagnosis and may represent candida infection. Patients with HIV infection with CD4 count below 200 are at risk of developing pneumonia from pneumocystis. Treatment consists of TMPSMX, atovaquone, pentamidine. Patients with low oxygen tension should also receive steroid along with antibiotics to limit inflammation and hypoxia during initial treatment phase. And it's not EBV causes infection mononucleosis which present with fever, hepatosplenomegaly, pharyngitis, posterior lymphadenopathy rather than anterior as in this patient. It's transmitted through saliva and respiratory stuff. Okay. Oh, strep pneumo, common bacterial cause of pneumonia, particularly community acquired birth. Patients tend to present with focal lung findings, including lobar pneumonia, as well as they tend to have more severe symptoms with abrupt onset rather than a 2 week course, along with evidence of immunocompromising. Okay, got it. Next.
24-year-old newly-gravid woman comes to the physician because of 3-day history of pain with urination and urinary frequency. She has she has a 1-year history of frequent bladder infections characterized by similar symptoms. The infection occur after sexual intercourse and resolve. The infections occur after sexual intercourse and resolve with antibiotic therapy. She has no history of serious illness and takes no medication. She is currently sexually active with one male partner. They use condom consistently. Examination shows bladder tenderness and urethral elevation. No other abnormalities are noted. Urine culture grows E. coli. Which of the following is the most likely to prevent recurrence of this symptom? Okay, ready?
Mhm. Prescribe antibiotic to be taken following sex. UTIs classically present in women with dysuria, urinary frequency, urgency, superpowering disorder. They are often caused by E. coli and gram-negative enteric chloride. If untreated, bacteria can travel up the ureter to infect the kidney, resulting in pyelonephritis. Urinalysis typically show leukocyte and nitrates along with white blood cell of microscopy. Treatment includes antibiotics covering common pathogens like E. coli. Recurrent UTI can be a result of congenital urinary tract abnormality. UTI are more common in women due to shorter urethra and favorable regional environment for growth. In addition, sex can introduce bacteria into the urethra, leading to recurrent UTIs. Therefore, antibiotic treatment taken following sexual intercourse can lead to then prevent the UTI in this patient. It is not CND. What was I? Perform cystoscopy to rule out the Truser instability is used in evaluation of reactive bladder. Reactive bladder is caused by the Truser muscle instability, commonly results in urge incontinence, which presents with the urge to void, followed shortly by leakage of urine. While UTIs can present with urinary urgency, this patient has no leakage of urine. Again, overactive bladder less likely. Perform cystoscopy to rule out anatomic cause may be helpful in the diagnosis of congenital urinary tract abnormalities. Congenital urinary tract include, but are not limited to unilateral renal agenesis, fused kidney, ureteral stricture and stenosis, ductless collecting system, posterior traverse, bladder agenesis, bladder dystrophy, hypoepis- eh, hypoepispadias, urethral strictures. Diagnosis is of basic urethral reflux, hydronephrosis, and congenital urinary tract is with ultrasound of the kidney, avoiding cystourethropy. Okay. Congenital urinary tract abnormalities present with frequent UTIs in infancy and childhood. This patient has more than has a more recent, like 1 year history of UTI. Okay, anything congenital, less likely. Okay, next.
An asymptomatic 32-year-old man comes to the physician 2 days after his male sexual partner was diagnosed with gonorrhea. He has not had penile discharge or dysuria over the past 4 months. He and his partners have unprotected sexual intercourse several times weekly. 4 months ago, HIV testing of the patient and his partner was negative. Examination shows no abnormality in gram stain of the mucus from a urethral swab and is negative for diplococci. A urethral culture is ordered. He gives a written consent for HIV antibody testing, serological testing for syphilis. Which of the following is appropriate next step in therapy? Ready?
Yes. Self-reaction in doxycycline Neisseria STI, gram-negative diplococca and cause pharyngitis, urethritis, epididymitis, vaginitis, cervicitis, PID, can also cause proctitis in patients who have septic anal intercourse, as well as the disseminated infection if it persists untreated. In male patients, it most commonly presents as urethritis. Can you hear me?
Yes, yes.
Yeah, urethritis with mucopurulent discharge, although it may also be asymptomatic. In contrast, when patients with disseminated infection, there are often no preceding symptoms suggesting STI. This patient presents with fever, malaise, but wait, am I in the right patient? Yeah, he has fever and malaise. I don't think they say all that. These patients present with fevers, malaise. Oh, these patients. Okay. Fever, malaise, polyarthritis, oligoarthritis, tenosynovitis, vesicular dermatitis, vesiculopostal dermatitis. They may also present solely with pulmonary arthritis of one or more extremities, joints, joints. Evaluation of these patients with exposure to STI or with symptom of urethritis includes gram stain and culture of a urethral swab. In gonorrhea, organism may not be visible on gram stain because gonorrhea is an intracellular organism. Cultures of gnat, cultures or gnat of the urine or urethral swab often yield the diagnosis. Screening of extragenital infections with oral and rectal swab is also recommended in non-monogamous men who have sex with men. Testing and treatment for co-infection with chlamydia. While testing is being completed, patients with a known exposure to STI should be treated appropriately. Antibiotic therapy treatment often consists of intramuscular ceftriaxone and azithromycin or doxycycline to treat for potential chlamydia infection. Next.
An unconscious 32-year-old woman is found by a nurse outside the emergency department. There is gunshot wound to her right temple. She does not have an advance directive and an organ donor card among her possessions. On arrival, she is unresponsive and has glaucoma cycle score 3. Her pulse is 48 per minute, respiration 8 per minute. Blood pressure 180 by 100 millimeter mercury. Pupils' eyes are dilated and non-reactive to the light. She is intubated. Mechanical ventilation started initial after fluid resuscitation. Her hemodynamic status is stabilized. A CT scan is of the head shows large intracranial hematoma with a massive midline shift. After consulting with the neurosurgeon, the most likely. Okay.
A moment between police and organ procurement. Okay, I guess not the police, public organ procurement. Okay, it's the local police department. This patient presents with gunshot wound that may or may not be self-inflicted, in addition to requirements to report abuse or suspected abuse to children and old people. Almost every state in the U.S. has a legal requirement to report non-accidental or suspected non-accidental injury. Such injuries include those sustained by firearms, knives, and other sharp implements. Some states also include provisions for reporting powder burns, inhalation burns, large burns, or other type of burns that may be reasonable that may reasonably be connected to illegal activity. Some states have specific statutes relating to the reporting of injuries that may be the result of domestic violence. Almost all states mandate that such injuries be reported to the local or state police department. Physicians should be aware of laws pertaining to reporting on non-accidental injuries in the state. It's not key. Organ procurement specialists are appropriate to consult regarding organ harvesting in deceased patients who are organ donors. This patient is not deceased. Reporting a possible violent crime to the police is more appropriate. Okay, next.
Okay, can we take a break for 5 minutes?
Yeah, sure.
Okay, I'm coming.
Mhm.
A 45-year-old woman comes to the office. I can see your screen.
Still not? You should
Yes,
be able to.
now. A 45-year-old woman comes to the office because of a wound of her right foot that she first noticed 8 weeks ago. During the past 3 days, it has increased in size and depth and has become moderately painful. She does not recall any injury to her foot. She has type 2 diabetes mellitus and hypertension. Her medications are insulin, atorvastatin, lisinopril, daily aspirin. She is 163 centimeter, 5 feet 4 inch tall, weight 95 kg, BMI 36 kg per meter square, temperature 102, pulse 80 per minute, respirations are 16 per minute, blood pressure 140 by 95 millimeter of mercury. Examination shows a 3 by 3 full thickness wound over the second and the third metatarsal head of the plantar aspect of the right foot. There is necrotic tissue and eschar, but no exposed tendon or bone. The plantar aspect of the right forefoot is tender to palpation. Dorsalis pedis and posterior tibial pulses in the right lower extremity are 1 plus. Sims Winstein 5.07 monofilament testing shows absent sensation over the right foot. Which of the following is the most appropriate next step in the diagnosis? Ready?
Yes. It is MRI of right foot. MRI of right foot is most appropriate next step in this patient. The patient has polycontrol diabetes and is presented with fever, worsening foot pain, ulceration overlying the second and third metatarsal heads on the plantar aspect. Because of this, a thorough workup is in a thorough workup into any underlying infection should be pursued, particularly MRI. Combination of factors leads to increased risk of both infection in diabetic patients. These include immune compromise inherent to diabetes, decreased sensation in feet, allowing deep wounds to go undetected by patients, decreased motor function leading to altered pressure points and swelling of the lower extremities, and decreased autonomic system function leading to impaired sweat regulation and increased risk for dryness, cracking, and fissuring of the feet, causing portals for bacteria entry. When a diabetic foot ulcer is present, X-ray of the foot will help to evaluate for the presence of osteomyelitis abscess and gas in the soft tissue, either of which will require surgical management and will dictate the treatment plan for this patient. Surgical management is generally the definitive treatment, though antibiotics should be initiated immediately. Conservative measures can be pursued first if medically appropriate for the patient. Arterial Doppler ultrasound of the lower extremity is pursued when there is concern for acute ischemia as a result of arterial thrombus or embolism in the lower extremity. Signs and symptoms include a cold, painful foot, lack of pulses. This patient has like 1+ pulses and pain. They do not generally cause ulceration as that is more chronic course, making this incorrect. Acute limb ischemia is medical emergency. It, yeah. Arteriography of the lower extremity is performed when there is concern for arterial insufficiency. Patients with which there is concern for arterial insufficiency will generally have a history of vascular issues like coronary artery disease, stroke, and prolonged development of ulceration of the feet. In contrast to this, patient ulceration caused by arterial insufficiency generally present distally on the terminal portion of the phalanges and are small but deep. It will be uncommon for arterial ulcer to present to the second and third metatarsal head on the plantar surface of the foot. Furthermore, arteriography will not address the underlying cause of this patient fever. Okay, next.
Yes.
Mhm.
A 27-year-old a 27-year-old woman comes to the physician, 6-month history of increasing pain and progressive swelling and stiffness of her ankles. Despite near despite nightly application of the ice to her ankle, ibuprofen therapy decreased activity during the past 3 months. Her pain has worsened. She has had swelling of her ankles throughout the day. She has had morning stiffness of her ankles. She has sustained no recent trauma to her ankles. No recent trauma to the ankle. She has she had a severe right ankle sprain in the college. Her only other medication is oral contraceptive. She is an avid tennis player and plays twice weekly. Vital signs are within normal limit. Vital signs are within normal limit. Examination shows swelling and moderate effusion of both ankles. Range of the motion of the both ankles is full but produces mild pain. X-ray of the ankles are shown. Which of the following is the most likely cause of this patient symptoms?
Mm, what is happening with the ankles? I do not know. Mm, she's 27. Between gonococcal and rheumatoid.
She had a morning stiffness and she had multiple pain on the ankle and
Swelling in her throughout the day, and she has had mornings. Okay, I guess she's so young for rheumatoid arthritis. It's kind of young. Why is it not gonococcal?
here she has no sexual history.
Mm,
She is a
okay.
tennis player.
Mm,
RA
okay.
can happen.
Okay. Rheumatoid arthritis, right? Rheumatoid arthritis is autoimmune disease that causes extensive inflammation of in synovial tissues. This clinical course is characterized by joint destruction, periarticular bone loss, and synovial hypertrophy, along with extraarticular manifestations such as rheumatoid nodule, pulmonary fibrosis, skin rash. Patients often present with symmetric involvement of multiple joints, most commonly the metacarpophalangeal and proximal interphalangeal joints of the hand, with X-ray showing articular erosions, progressive joint space narrowing. Other deviation of the fingers along with boutonniere swag deformities occur. This patient is presenting with bilateral ankle pain and swelling without signs of osteoarthritis or degenerative changes on X-ray. Testing includes rheumatoid factor, recent N anticyclic citrullinated peptide test. Treatment of rheumatoid arthritis involve use of NSAID and disease-modifying drugs such as amitriptyline. For this patient, rheumatoid arthritis to most likely diagnosis because of bilateral joint involvement, lack of trauma, and the presence of morning stinging and moderate ankle effusion. Gonococcal arthritis is caused by Neisseria, STI, diplococci, cause pharyngitis, blah, 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 we know that. Stating gonococcal arthritis, the synovial fluid leukocyte count will be greater than 20,000 to 50,000, but no organism will be visible on grand stain because Neisseria is intracellular. Treatment is antibiotics. Because of lack of fever, bilateral presentation, and only mild pain on echo range of motion, rheumatoid arthritis is the most likely. Okay. It's not transient osteoporosis is a relative rare disorder that is more likely to occur in middle-aged men or during a patient's pregnancy. Patient may show femoral neck metaphysis, edema. Transient osteoporosis is less likely in this patient that is experiencing bilateral ankle pain, and X-rays of the ankle do not show significant pathology. Okay, next.
Yes. A previously healthy 24-year a previously healthy 24-year-old woman comes to the physician because of 2 week history of fatigue and easy bruising. Her temperature is 37 degrees Celsius, pulse 100 per minute, respiration 20 per minute, blood pressure 100 with 60 millimeter mercury. Examination show ecchymosis of over the lower extremity. Lab studies shows hemoglobin 9.2, uh, leukocyte count 53,000, lymphocyte count 53,000, lymphocyte 10%, myeloblast 90%, platelet count 63,000, creatinine 1.9, and LDH very, very high. A bone marrow biopsy confirms the AML. Which of the following is the most appropriate next? Ready?
One moment. Oh, Jesus.
What is your
Okay.
diagnosis?
They gave the diagnosis is AML.
Sorry.
Okay. They gave the diagnosis. I just don't remember what was the treatment for AML. I don't think it's packed red blood cells. The thing is 9. Transfusion. She's not really bleeding. Um, Renal ultrasound doesn't know if it makes sense. I don't know. And between hydration, hydration it will make sense, but urine alkalization, why? Between A and E. I guess I'll go with E. Should have gone with A. AML is a neoplasm arising from cells within the myeloid lineage that presents with pancytopenia and myeloblastic peripheral smear and bone marrow biopsy. Common presenting symptoms include fatigue, easy bruising, and bleeding due to thrombocytopenia, mm, malaise, fevers, and weight loss. Treatment is generally cytarabine and daunorubicin, and is sometimes followed by consolidation therapy and stem cell transplant. Though regimens vary depending on tumor characteristics, treatment of AML or baseline cell turnover can lead to tumor lysis syndrome due to the destruction of tumor cells, resulting in release of their contents, manifesting hyperphosphatemia, hypocalcemia, hyperkalemia, hyperuricemia. Hydration and urine alkalization oh, can help prevent resulting kidney um, injury. Calinization increases the urine pH, making uric acid more soluble and readily excreted. Also prevents precipitation of uric acid in renal tubules, which will lead to kidney injury. IV fluid also helps improve urine output and prevent further. Okay, they asked this question wrong. Which of the following is the most appropriate after they start the treatment? That's what they should have asked. Induction therapy is an important appropriate step, but the immediate condition of thrombolysis syndrome and AKI should be addressed first to prevent worsening during induction. Induction chemo carries the risk for significant electrolyte enlargement and okay. Next.
Yes, a 20-year-old man comes to the physician because of 3-year history of bruising without any trauma. He has not bleeding. He has not he has not had bleeding from his nose or mouth. He has no history of serious illness, takes no medication, vital signs are within normal limit. Examination shows ecchymosis in various stages of healing over the upper extremities. Results of complete blood count are within the reference range. His prothrombin is his prothrombin time is 20 seconds. INR2 partial thromboplastin time is 25 seconds. The patient is most likely have has a deficiency of which of the following? Ready?
One moment. INR PT is high. Ready. Let's see. Factor 7. Deficiency is a rare Factor 7 deficiency is a rare bleeding disorder caused by deficiency in blood clot in factor 7. This factor is produced by the liver and essential for formation of blood clot. The deficiency of factor 7 is usually inherited in autosomal recessive manner. Symptoms of factor 7 deficiency can range from mild to severe and can include bruising, nosebleeds, and bleeding after injury or surgery. Since factor 7 is a part of the extrinsic pathway of coagulation, it's expected that a patient will have normal PTT, normal bleeding time, and increased PT. Treatment of factor 7 depends on the severity of bleeding symptoms. My cases may not require treatment, while more severe cases may require replacement therapy with factor 7 concentrate or fresh frozen plasma. Complication of factor 7 deficiency can include joint damage from recurrent bleeding, and in severe cases, life-threatening bleeding episodes. Next.
A 42-year-old woman comes to the physician because of 3-year history of ringing in her ears. The sound gradually intensified during the first year and has been unchanged since that time. The ringing is more noticeable when she is in quiet environment but otherwise does not fluctuate throughout the day. She reports that her hearing is otherwise normal. She has hypertension treated with lithium. He has smoked one pack of cigarettes daily for 25 years and drinks one glass of wine daily. Her blood pressure is 130/80, and other vital signs are within normal limit. Examination of the external auditory canal shows no abnormality. Finger rub testing shows no abnormality. Auditory shows high frequency hearing loss bilateral. Which of the following is the most appropriate next step in the diagnosis? Ready?
Yes, yeah. It is no further testing necessary. What does she have? Tinnitus refers to internally generated sounds. The most common cause of tinnitus is sensorineural hearing loss, ordinarily resulting from noise trauma. The internally generated sound frequently mimics the frequency of the hearing loss. Other common causes of tinnitus include hypertension, diabetes, atherosclerotic disease, obesity. Other causes of tinnitus include Meniere disease and vestibulocochlear cranial nerve lesion, acoustic neuroma. For some patients, tinnitus is idiopathic, most but not all patients with tinnitus have hearing loss. The pathophys of tinnitus is unclear. Depression, anxiety, insomnia can worsen tinnitus. Um, Diagnostic workup may include audiometry to evaluate for hearing loss. Reimaging is only done if there is symmetry in sound perception across the two ears. Angiography is only done if the tinnitus is pulsatile, which suggests a vascular cause. No further testing is indicated for this patient. Management includes stress reduction, cognitive therapy, and masking with external sound to distract from the internal sound.
Next. An 18-year-old basketball player is brought to the emergency department 1 hour after collapsing during a game. He was successfully resuscitated at the scene. On arrival, he is awake and alert. His temperature is 37.1, pulse 80 per minute, regular respiration 12 per minute, blood pressure 120/80. Examination shows no abnormality. ECG shows left ventricular hypertrophy. Echo shows systolic anterior motion in the anterior leaflet of the mitral valve causing a subaortic obstruction. Which of the following is the most appropriate next step? Ready? It is HOCM, isn't it?
Um, Maybe, yeah. This young athlete, otherwise healthy, is A, the answer. This young otherwise healthy patient with collapsing during exercise in ECG showing left ventricular hypertrophy likely has HOCM, you're right. This condition, which is suspected to have autosomal dominant inheritance, results in hypertrophy of myocytes, leading to focal obstruction in the left ventricular outflow tract. Classically presents with syncope and sudden cardiac death in an otherwise healthy young adult. Due to the narrow left ventricular outflow tract, any hemodynamic influence that prevents the open of the tract, the stenting open of the tract, like low preload leading to low stroke volume caused by valsalva extending or hypovolemia will result in an exacerbation of the normal because of increased turbulent blood flow. Significant derangements in hemodynamic can cause complete obstruction of the left ventricular outflow tract, commonly causing obstruction by abnormal motion of the mitral valve. Resultant reduction in cardiac output leads to syncope. Arrhythmogenic foci are also a common cause of mortality. Medications that increase diastolic filling by reducing the pulse, such as beta blockers and non-dihydrocalcium channel blockers, are the treatment. Next.
A 1-year-old boy is brought to the office because his parents are concerned that his birthmarks have been increasing in size and number during the past 6 months. Growth and development are appropriate for age. Immunizations are up to date. He has no history of serious illness and receives no medication. Examination shows 10.6 to 10 millimeter tan brown macule over the patient's trunk, axilla, and the extremities. Which of the following is the most appropriate next step intervention?
Hmm. What does he have? What does he have? Uh,
She is on
of,
what?
she's on what?
Uh,
What do you mean?
like, what is your diagnosis?
I don't know. I don't. My brain is not working. I know. I see it in my brain, but I cannot see the name. I cannot see the name.
Neurofibromatosis, isn't it?
Neurofibromatosis. Neurofibromatosis.
Isn't it?
Yeah, it's the that's at the scoliosis with um the freckles, the black, and then the yeah. I think it's that one. Yeah.
So
So
why will do we go?
wait, isn't that the? That's not that one.
Cutaneous
That's
neurofibroma, cyclops, cutaneous neurofibroma, intellectual disability, leash nodule, optic glioma, pheochromocytoma.
that's the optic glioma one. So it's D. Got it. Get it. Got it. That's the optic glioma. It's ophthalmic examination. I confused it with the other one that has the
Tuberous sclerosis.
no. Tuberous sclerosis is not black. It's not the dark brown. There's
La-
another one.
yes, wait. Capholates for that one. Tuberous sclerosis,
No, tuberous sclerosis
hemar-
is not.
hematoma in the skin and the CNS. Okay,
No.
the three thing
Okay.
tuberous sclerosis. One is tuberous sclerosis. One is
No, I wasn't.
neurofibromatosis. Another, you were talking about the port wine stain. That one, isn't it?
No. I confused it. I was talking about Frederick. I don't. My brain went far. I was
Frederick
thinking.
ataxia.
Yeah, my that's what I'm saying. My brain went too far. I know tuberous sclerosis is not brown. The things are not brown. Um.
Okay, no
Yeah.
problem.
Yeah.
Are you
And
tense for any reason?
I am. I don't know. I'm just tense. I don't know why. I just woke up tense today. I don't know why. But yeah. It's okay. Maybe I need to go back to sleep and wake up again.
Okay, we will leave early.
No, it's okay. I don't mind. No, I don't mind. I don't
Okay.
mind. This actually distracts me, so I don't mind. NF1 is genetically inherited disorder caused by
Tomorrow
NF1.
you have to leave early, isn't it? Like
Yeah.
you
I
have
have
to
to
pick
go.
somebody. Okay.
Yeah, yeah, for yes. But only like 15, maybe like 15 minutes, 20 minutes early. Not that much. The type 1 is genetically inherited disorder caused by defect in NF1, the gene that encodes neurofibromin from chromosome 17. It follows an autosomal dominant pattern and is of inheritance. It's characterized by a constellation of cutaneous manifestations like neurofibromas, plexiform, hyperpigmented macule, and axillary freckling. Okay, now I'm seeing it. Variety of CNS tumors, including optic nerve glioma and irisomatomas, and bony abnormalities such as long bone dysplasia and sphenoid wing dysplasia. This patient has several hyperpigmented macules, also known cafe au lait spot, and should undergo an ophthalmic exam to assess for optic nerve glioma. Patients are also at high risk for developing astrocytomas, brainstem gliomas, and soft tissue sarcomas. NF2 has different constellation of findings, including bilateral acoustic schwannoma, cataract, meningioma, and ependinomas. Yeah, makes sense. Next. Oops.
3 hours after undergoing 3 hours after under 3 hours after undergoing placement of IV line using routine universal precaution and IV fluid therapy, fluid therapy and hospitalized 2-year-old girl has the onset of generalized itching rash. She was admitted to the hospital today because of 3-day history of fever and diarrhea. As a newborn, she underwent surgical repair of a myelomeningocele and a creation of VP shunt. She is not recently, sorry, she is not currently receiving any medication. Vital signs occurred 3 hours ago. Okay, wait 1 minute.
Okay.
Okay, I was reading this question.
Mm-hmm.
Okay, again. 3 hours after undergoing placement of an IV line using routine universal precaution and beginning IV fluid therapy, a hospitalized 2-year-old girl has the onset of generalized itching rash. She was admitted to the hospital today because of 3-day history of fever and diarrhea. As a newborn, she underwent surgical repair of the myelomeningocele and a creation of VP shunt. She is not currently receiving any medication. Vital signs 3 hours ago and now are temperature 38, now 37.8, pulse 110, now 160, respiration 24, now 40, blood pressure 105 by 65, now 80 by 50. Yeah, examination shows diffuse raised erythematous lesions with pale centers. The upper and the lower extremity appear mottled. Capillary refill time is 5 to 6 seconds. The remainder of the examination, including fundoscopic and neurologic examination, shows no abnormality. Which of the following is the most appropriate? Which of the following is most likely to have prevented this patient's current condition? Ready?
Yes. Avoidance of latex gloves. Anaphylaxis, severe type 1 hypersensitivity reaction, presents following exposure to an allergen, most commonly medication, food, insect bites. It's mediated by activation of IgA, which leads to the release of histamine and cytokines from mast cells and basophils. This subsequently leads to acute inflammation and profound vasodilation. And the multiple organ system, generally the cardiovascular, respiratory, GI, and tegumentary system. Symptoms include rapid onset of bronchospasm, with dyspnea and wheezing, urticaria, flushing, nausea, emesis, edematic lips and tongue, and hypotension, tachycardia. When severe and untreated, can progress to circulatory collapse with cardiovascular arrest and death due to asphyxiation and airway obstruction. Treatment includes the administration of epinephrine, antihistamine bronchodilators, and steroids, as well as IV fluids. Severe cases may require endotracheal intubation and the administration of vasopressor. Epinephrine, a potent vasoconstrictor, should be given first as it decreases airway edema and hypotension. Patients with myelomeningocele and other forms of spinal bifida exhibit a high incidence of latex allergy. Oh, you didn't know that. Avoidance of latex gloves and other latex containing products is recommended in the care of these patients, patients as well as with patients allergic to bananas or avocados, as antibodies against antigen in these fruits can be cross-reactive with it. Whoa, did not know that. Okay, it's not a revision of shunt can increase the risk of latex sensitization in patients with spinal bifida due to repeated exposure to latex antigen, making this choice incorrect. Okay, next.
Previously, he'll 29-year-old man comes to the physician because of 6-week history of intermittent, increasingly severe upper abdominal pain. He has not had fever, chills, weight loss, or intolerance to fatty food. Over-the-counter famotidine has provided minimal relief. He has smoked one pack of cigarettes daily for 10 years. His temperature is 37, pulse 68 per minute, respiration 18 per minute, blood pressure 120 by 82 millimeter of mercury. Abdominal examination shows epigastric tenderness to palpation. The remainder of the examination shows no abnormal test of the stool for occult blood is positive. Esophagogastroduodenoscopy shows 1.5 centimeter ulcer along the laser curvature of the stomach. There is no active bleeding. Biopsy results are shown. Smoking cessation is recommended. In addition to lansoprazole therapy, which of the following is the most appropriate? Is it Helicobacter H. pylori?
Looks like, is it? I
The
mean, what is it? The little things or the big thing?
sorry,
What is the Helicobacter pylori? Is it the little things or the big thing?
the big thing.
The big thing.
See, the stem seems like H. pylori.
Oh, it seems like it's okay. Okay. I mean, it must be like they're only giving antibiotics, so it
Yes,
must be. I forgot what was the antibiotics for it. It was no, not metronidazole. It's ciprofloxacin. No, tetracycline. I know. I don't remember. I'm trying to remember the sketchy for that. Claritomycin. There was claritomycin. There was what was the claritomycin? Was it tetracycline? No, it was. There was not tetracycline. I think it was this one. It was macrolide, PPI, macrolide, PPI, the amoxicillin box. Yeah, it must be that one. Okay, ready?
yes, ready.
Let's see if I remember my sketchy. I need to read sketchy first. Yeah, it's claritomycin and amoxicillin. Peptic ulcer disease, the presence of ulcers in the stomach or duodenum. Okay, which typically presents with worsening abdominal pain related to consumption or lack of consumption. So pain with food, it's gastric. Pain without food is duodenal. Peptic ulcer disease is strongly associated with infection of from Helicobacter pylori, persistent inflammation related to Peptic ulcer disease can result in complications including fibrosis, stricture, hemorrhage, perforation. EGD with biopsy of a peptic ulcer is a sensitive and specific method for diagnosis H. pylori infection and observing signs of inflammation. As seen in, I guess, the photo, H. pylori organism appears as short spiral-shaped bacteria in the gastric mucosa.
Where is
Wait,
the
so is it?
spiral?
I thought you said that
You,
was the big thing.
you are looking for the spiral.
Yeah, I'm like, I was like, is it the little things inside or is it the big? I mean,
Normally, the H. pylori has the like flagellated thing, flagella, like what can I say? Like amoeba.
mm-hmm.
Okay, leave it. Okay,
But I feel like I've seen this picture somewhere before. I don't know if it's your word or whatever, but I feel like the picture is important. Like I've seen it somewhere.
yeah.
Eradication therapy using triple or quadruple uh, combination therapy can eliminate the bacteria and permit healing of the peptic ulcer, generally with with few complications if you manage promptly. In addition to PPI such as lansoprazole, treatment of H. pylori includes two antibiotics to reduce the risk for treatment failure. Typically, antibiotics chosen are macrolides and amoxicillin. Next.
A 2-week-old boy is brought to the physician because of 5-day history of progressive rash that began at a site on his scalp when an electrode was attached during labor. Despite application on topical antibiotic, the rash spread to his trunk and extremities. He was born at term following an uncomplicated vaginal delivery. Apgar score were 8 and 9 in 1 and 5 minutes respectively. Initial examination showed no abnormality. He is currently at 30 percentile for length, 75 percentile for weight, 25 percentile for head circumference. Vital signs are within normal limit. Examination shows erythematous patches with overlying vesicles containing clear or cloudy fluid over the entire body. Appropriate treatment of this patient is most likely to prevent which of the following acute manifestation of this condition.
What condition does he have?
Ready?
Okay. Yep. His encephalitis. What does he have? Oh, herpes. This patient vesicular lesions are likely caused by herpes simplex virus contracted during his vaginal delivery. Treatment with antivirals will prevent the development of herpes encephalitis. This patient mom most likely had an unrecognized genital herpes infection, or which often presents with painful vesicles in the genital area like vulva, vagina, cervix, perineum, and associated symptoms of fever, chills, and inguinal lymphadenopathy. Most cases of genital herpes are caused by HSV2, however, HSV1 has also been associated with genital herpes infection. In pregnant patients, the infection may pass to the newborn during delivery to an, to an ascending infection following spontaneous rupture of membranes or from passage to the infected lower genital tract. To prevent this interpartum transmission of infection, Cyclovir can be used to suppress outbreaks. The C-section is required if hepatic lesions or symptoms are present on the cervix, vagina, vulva at the time of labor. Common neonatal complications include vesicular skin lesions and ocular movement, whereas neonatal encephalitis is a severe complication of the infection. Herpes simplex encephalitis often present with fever, seizures, lethargy, and poor feeding. Diagnosis is made with lumbar puncture and CSF analysis. Okay,
Okay, we have finished
we
the
are